Hi, everyone. Good morning. Thank you for joining us today for the final webinar in the Revenue Cycle Improvement webinar series. Today's session will focus on middle and back-end revenue cycle improvements. Please take a moment to enter your name and title in the chat box so we know who's with us today if you haven't already. And while you're doing that, I'll ask Caleb to pull up the pre-polling questions for us. Today's session will be recorded, and the recording and slides will be made available online following the webinar for all sessions in the series. Continuing education credits are also available through ACHE. A survey will be emailed this afternoon to obtain credit for the webinar series. Give everybody another 30 seconds or so on the polling question. And while you're doing that, I'll go ahead and introduce our speaker. Our speaker today is Amy Graham, Senior Consultant with Stroudwater Associates. Amy is an experienced healthcare executive providing vision and direction in finance and revenue cycle and serving clients in the pharmacy, laboratory, hospital, and rural health clinic space. Amy has over 20 years experience in maximizing the accounting, finance, and revenue cycle processes for healthcare organizations. Her professional expertise includes month-end accounting consolidations for divisions with 50 to 200 million in net revenue, creation of accounting policies and procedures for intercompany transactions, strategic analysis to determine long and short-term organizational goals, development and direction of budgeting and forecasting activities for multiple entities, and understanding of synchronization of revenue cycle management to financial statements. Previously, Amy served as Senior Vice President of Revenue Cycle Management for Nashville-based Path Group, among many other notable positions. I'll be monitoring the chat box throughout the webinar, so please feel free to chat in questions at any time. I'll now turn it over to Amy to get us started. Amy?
Thanks, Shannon. I appreciate it. And thank you, everyone, for coming back for this third part in this series. It's always nice to see returning guests and returning people and to know that you all are as excited to talk about revenue as I am. And thank you to the National Rural Health Resource Center for just sponsoring this webinar today. The funding source, it is funded by HHS and HRSA with their funding. And so we just have the funding statement there to just show you where that's coming from. Now, as we did with the other two webinars that were done, we're going to get on the same page. So we're first going to talk about an overview about the revenue cycle process, and then we're going to get into some nitty-gritty, talking about transaction processing, where we're going to talk about claim submission. And then also talking about, within that transaction processing system, talking about the inbound processing, what that looks like, and the activities included there. And then also having an accounts receivable management. What are those activities and what do we need to look at and monitor, and what are some best practices related to that? So let's get on the same page. As we have shown in the other webinars, we see that revenue cycle management is very robust, and you can have activities that are in the claim life cycles. You have front-end activities with pre-visit and visit. Then you have transaction processing with claim submission and inbound processing. That's what we're going to talk about today. And then back-end activities with accounts receivable management. And then in the first webinar that we did, we talked about the pre-claim activities as well as analytics that you can use to monitor and measure the activities within revenue cycle. And these items actually happen before the claim is ever generated, but these are all touch points to one another and they depend on one another. And failures in any stage of these processes do have impacts downstream as well as back in the beginning. And all of this is on a foundation of month-end closing, cost reporting, compliance, performance management, and IT and quality. So we're going to jump right in and really talk about starting with the transaction processing, claim submission. So when you think about claim submission, the first part you think about is charge entry. Now, last time we talked about coding and charge capture and encounter documentation, but really when we talk about charge entry, we're thinking about procedures. Have all the procedures been entered into the system for both the physician side as well as the ancillary side? Are there any supply costs that need to be counted? Have they been entered into the system? So when you think about charge entry, it's gathering all of this information. Is it in a common system? And then that common system, those charges are then used to create the final bill, your final bill that you will send to it. And so when you think about this charge entry process, we have a few best practices that we'd like to share with you. So, really, what you want to do is you want to engage your clinicians in the facility wide policies regarding chart finalization to facilitate any completion of charge entry. So, when you think about it this way, the services have been provided to the patient's received the services, the patient has been discharged, but then you get to the point of getting that final bill created. And if no one is monitoring that, and if there is an engagement by both the clinicians as well as the revenue cycle team to make sure that all those charges are captured, then you end up getting late charges that come through. And late charges are usually they come after the bill is dropped and you have to refile with the insurance company and do that. And so you want to develop processes to ensure complete and accurate charge capture and accurate claim submission so that you will maximize the reimbursement, so that you're not having to send corrected claims and manually touching those encounters, those claims again. What you ought to do is also a best practice is to train your team to recognize the errors and empower change. And when I talk about this, it could be like procedures and drugs and supplies that are likely to be billed together. So if you were to say that you would have a cataract surgery done, well, then you're going to have the cataract lens included. And then you might have a medication that goes along with it. And so when your revenue cycle team gets the claim, they need to know, oh, is it this has a charge for an implant, but we haven't charged, the supply cost, but we haven't charged for the procedure itself. Where's the charge for the procedure? And let's go find that charge and figure out where it is so that we can get a complete bill dropped. And then also services that cannot be performed without that cannot be performed without other billable services, drugs or supplies, and then diagnosis codes that are likely to drive denials or requests for additional information. So you want to train your team to recognize these items and proactively address them, because what they're doing is they're fixing it before it ever goes to the insurance company. Because if they send it to the insurance company, chances are it's going to get sent back and they'll have to fix it then. So why not fix it the first time and get to the root cause of the problem? And then you can monitor the performance of your charge entry department by reviewing a report that a lot of people call the DNFB. You might have heard those letters used before. It's an acronym, so it's healthcare, so there's an acronym there. And DNFB stands for discharged, not final bill days. And so what you are doing is you're looking at how many claims have actually been discharged, but there's not been a claim submitted to the payer yet. And you want to review that compared to what's your dollar amount that's been discharged, but there's not a final claim generated, compared to the overall charges of the hospital, to look at how many days you have outstanding. Now, there is going to be a lag there with this, but you want to keep it to as minimal as possible. And you drive that through creating policies and processes in place with your clinicians. So, again, these best practices are working hand in hand with one another to maximize the greatest efficiency. And then another area to look at is a late charge report. And that is what that looks at are charges that are dropped after the final bill. Are you going back and monitoring? Look, we have, this one department historically is dropping charges so that we see it after the fact. And what you want to do is to empower your team to tell you and let you know when this is happening rather than just going, yep, it's that same department again. Yes, we know. There it is. Let's just write it. We'll rebuild a claim, because you probably have somebody who's manually having to correct the claim and get that billed out the door. And they know the common departments that are doing it. And so if you empower them to make the change, to tell them what's going on, then you can fix it at the root cause and get those charges dropped on the first bill, and thereby creating efficiencies for your team. In looking at it, the next area that we're going to look at is claim scrubbing. And I put all of these together because, they sort of work hand in hand with each other, but they're different. So we're going to talk about it, but we're going to talk about it together. Claim scrubbing, pre adjudication, claim submission, and EDI management. Now, here's what I want to first say. Up until this point, all of the activities that we've talked about prior to now, all of that's being done, a lot of revenue cycle activities. But when you think about it, you still have not sent a single bill to the insurance company. You've still not sent a single bill to the patient. There has not been an opportunity to send it out. Those activities are happening behind the scenes and things are going on. But when you think about it, still have not made it through the process. When you get to this stage, these are clearinghouse activities. And a clearinghouse is just it's a company that's out there that is taking all of the information that's being sent. It's taking the hospital claims, the outpatient clinic claims, physician claims, and it's formatting it into the format that the insurance company is wanting to receive. And so claim scrubbing, it happens at your clearinghouse, and the claims are not ready to go out until they get clean and are working through that. And so when looking at these activities, you have claim scrubbing. What does that mean? Well, the clearinghouse, so this outside third party company most likely, is evaluating the services to make sure that they're ready to be built. Is all of the information included? Do you have a patient name? Do you have a subscriber ID? Do you even have an insurance coverage? Do you have their demographic information? Is all of that information that is needed on your bill captured in order to go through? So, when thinking about it, they're scrubbing the data. Like if you think about scrubbing a floor, they're scrubbing the data to get it clean before it goes to the insurance company. Because by getting it clean, then when the insurance company, they're not going to send it back and go, you did send us a insurer ID number. Our insurer ID number is 7 digits. You sent us 5 digits. We won't accept the claim. The claim scrubber should be set up to already know that information and have it in there. In the claim scrubber as well, that's where you would want to put some modifiers. Could it be that you have a specific payer that has just gone crazy? And yeah, we all know payers, they do tend to have their own rules and their own procedures for how they want things, and it's not standard between two payers. You would like it to be, but a lot of times they have their one-off plans. And so what you can do is set up the claim scrubber that when this claim comes through, it applies that modifier that the payer wants to see and goes through. Rather than building it in your charge master, because you don't have to use that modifier every single time, you can put those one-off scenarios into your claim scrubber, into your clearinghouse edits to get that done. It can also, I've seen some claim scrubbers or clearinghouses out there that when they put the information through, they replace the CPT with the HCPCS code because they know that the insurance company always requires the HCPCS code instead of the CPT code. The claim scrubber will also help you identify any NCD or LCD. Those are two other acronyms you may have heard out there. That's your national coverage determination or your local coverage determination edits in place to where locally a payer has said, we don't accept these two codes together. You can only bill one or the other. You can't bill both of them. And so the claim scrubber will get the claim fixed so that you won't get that error downstream. So let's go on to pre-adjudication. What's pre-adjudication? This is actually insurance verification and identification of bundled codes. So what it's doing is it's taking the claim and getting it ready to send out. And then as we talked about in insurance verification before, this is where you can, look to see in this same area what the benefits are available for the patient. And so the clearinghouse is doing a pre-adjudication. And then what it's also doing is it's taking the information that you sent. Because if you think about all of the people who are on this call, we all have different, we might have, there are about 5 or 6 major companies out there for EHRs, but we all have our own CDM. My CDM is not like your CDM, and it's not like our neighbor's CDM. And so, what it is doing is the clearinghouse takes all of this information and formats it into the format that and converts it into the format that the payer wants to receive. So they get all this disparate information and they take it and they say, yes, here we're going to put this in this cell and this in this field and this in this one, and we get it sent out. And what's really nice on the back end, when you're working in this clearinghouse, you go and you look at the claim and you say, show me the claim. And it pops it up in a pretty, UB form. You see it in a UB form, or it brings it up in the pretty HICFA form. And only someone in revenue cycle would think a HICFA is pretty. So anyway, you pull it up in the HICFA form and you see it. But what you're not seeing is in the background that the clearinghouse has actually taken that and formatted it and is sending it out. So your clearinghouse is really important for getting that. And a lot of times when you have, if there's something broken and the insurance company is not receiving it, go back to the clearinghouse to say, has anything changed here? Because maybe something was changed inadvertently and you need to fix it. You also Another activity that your clearinghouse performs for you is claim submission. Printing and mailing of paper claims. This actually happens. You think, we print claim, every payer just goes electronically. But there's some one-off payers that don't receive claims electronically. They still want a paper claim. And your clearinghouse is taking care of that for you. And then you have EDI management. EDI management is the lesser known piece of a clearinghouse, but it's one of those that you really ought to pay attention to. And so we'll talk about these best practices here on the next slide. So what you want to do is we've talked about the clearinghouse and how that information works with each other and what it's doing. But what you want to do, best practices, utilize the insurance verification functionality that's in that clearinghouse because when you submit your claim, it has to go through the clearinghouse. So, it's going to tell you the information that it needs. And to recognize that Claim Scrubber evaluates the services that are being billed, but it can't identify likely missing charges. So it can say, hey, here are the NCD and LCD edits. You can't build these two together, but it can't tell you if there's a third CPT code that is likely missing from this combination. You're still going to need your team to do that. So recognize that claim scrubbers don't catch everything, but also leverage the clearinghouse to handle one-off requirements from the payers. Leverage them to do that rather than having a person sitting at a desk who's manually catching all of these things. Use the clearinghouse, program it to do it, because instead of that person having to catch all 15 of those errors that come through, you set it up and you never have the error again. You want to evaluate. Make sure that you are evaluating the scrubbed claims with warning edits to determine if process updates are needed. Now, the insurance companies, they're going to give you warnings back, or the clearinghouse will give you warnings back to say, hey, this information is missing. We need to fix this. What does this look like? So you want to make sure that you are checking those warning errors because it could be that if you've tweaked something on the front end, just like one field, you don't have that error going through anymore, and you're not going to get that warning coming back. And then you want to evaluate scrubbed claims, or you want to work batch submissions to ensure all claims are submitted electronically. We'd like to think that, it's just clearinghouse just works great. And it's not a fault of the clearinghouse, but, just even a flicker of power when we're watching TV or we're watching, something on YouTube and there's a flicker in the power and all of a sudden we lose our video. Well, the same thing happens with your claims that are being submitted out. Something could flicker between your system and the system that's receiving it, and those batches get dropped. So you want to monitor your batch submissions to make sure that everything makes it through electronically. And then acknowledge that paper claims are still being mailed to some payers. Not every payer is receiving it on paper, or not. Let me say that again. Not every payer is receiving it electronically. There are still some small payers out there that want to receive it via paper. They want the HICFA 1500 form. They want the UB. But that information is being generated out of your clearinghouse, or it could be generated out of your clearinghouse. Your employees don't have to go and sit and type it up on an old-fashioned typewriter to get the information through, or even printing it out on their system. That you can leverage your clearinghouse to do that. And then what you want to also do is to aim for 99% clean claim submission. Now, what does that mean? That means that 99% of your claims make it through without anyone having to touch it. That it gets dropped out of the patient gets discharged, all the charges are captured, they flow to the clearinghouse and then out the door. That's what the goal is to have 99%. And really, I wanted to put like 99.5% because that's really where the best shops aim for. But, 99% is pretty close too. So you want to just manage it and make sure that your claims are going through, no problem, no manual intervention is needed, and you can utilize your staff to do other functions instead of having to work a clearinghouse claims. Other clearinghouse best practices. I put this on a separate slide because we really wanted to make sure that you recognize that there are claim acknowledgement reports that are in the clearinghouse tool. And what that means is that there is that when those files are generated from the clearinghouse and sent to the payer actually sends back an electronic response. It's almost like a read receipt on your email. Got it. Thanks for the claims. Have a great day. They'll acknowledge it. And so when working that, you can fix any problems or you can identify that, you know what? We sent out batches on the 24th of January and we didn't get a thank you back from the payer. Where's my thank you? Similar to when I was working with Shannon, it's like, Shannon, you didn't respond that you got this presentation. Well, because when I sent it, it didn't make it there. So same thing happens with your claims that are being sent out. Make sure that you get a response because chances are, if you're not getting a response, they didn't receive the file. And it's very easy to just go back into your clearinghouse and release that batch of claims again to get the thank you from the insurance plan. And so by doing that, looking at those acknowledgement reports and working them daily, don't let them slide. If you work them daily, it's very easy to take care of one or two. If you let them slide and get to the end of the month, then you may have what 60 of them to have to work. And so by working them daily, you're staying on top of it, easy peasy to do, and go on. And then claims that are rejected from the payer will need to be corrected before they can be submitted. I always I refer to this as like a screen door. That you've actually sent the claim and then it's hit the screen door and bounced back. And they said, "Nope, you are not the right size to get through our screen door. You've been rejected. You've got to fix all of those errors before we can receive the claim." I mean, then those errors could be something like you're missing a taxonomy number, you're missing a CPT code. Claims are going to get there, and even if it's rejected from the clearinghouse, the payer doesn't have an opportunity to adjudicate that claim. You won't get paid if they don't receive the claim. And so then also go back to these rejected claims that have to be fixed. Is there something in an earlier process that needs to be fixed? Is there something in the insurance verification side, in the registration side, in your charge master, in the provider setup? Is there something in some of the earlier stages that needs to be fixed? That's what you want to look at and address. And then also just address them to make sure that they don't reject in the future because you can fix it one time and save yourself a lot of trouble on a lot of claims going forward, or you can fix every single one that comes through and do it forever. Now, here, I feel like we should sing. Oh, oh, sorry, I shouldn't sing this morning, but I feel like we should sing because now, inbound processing, this is where we are finally. How many minutes have I been talking to you about revenue cycle? This is the first time that we are getting communication back from the insurance plan to say that they are paying us for the services. I feel like bells and whistles should go off because we are celebrating the fact that we are now going to get paid. And so when looking at this, the first step is mail processing, scanning, and indexing. Mail processing, mail should go to a central location and a team trained on the importance of their position because this is the cash coming in. If you are not leveraging a bank, and we'll talk about that here in a minute, but this is where you will see cash coming in. You're going to see payer notices saying, with new policy updates to existing contracts. You may have CMS correspondence. Your rate letter is coming out for the next year for all of your different services. It comes through the mail. It's not coming electronically. It's old-fashioned United States Post Office mail is sending that to you. And those notifications are so important. So if you have the mail going to a central location and those people in the central location know to look out for that letter from CMS, or hey, here's a letter from Blue Cross Blue Shield, and let's look at this, and they know to escalate it quickly, then you're not going to have things that are of high importance that have a time frame attached to them that are just sitting on someone's desk because they don't understand the importance of it. And then also, if you get payments in the mail, I think they should be deposited daily. Don't let them sit on your desk. We all want the cash in our bank, right? Because we're all wanting to write a check or use our credit card or our debit card. We all want to do that. So deposit the payments daily. Don't hold them and wait till you get a week's worth. Go ahead and deposit the check now. That would just be a key process to put into place and a best practice that your mail comes in, that it's important. And then also scanning. Have you thought about scanning your information? That with teams working remotely now, when you have revenue cycle teams who are all working from home because of the pandemic, that when you have somebody who indexes the information and scans it, then the people working at home quickly identify the items that they need to work, and that highly sensitive items should be escalated to the appropriate teams. So the mail comes in, someone gets the mail, opens it, and rather than taking that piece of paper and sending it to someone's office and it sits on their desk, they can take it, scan it in, and email it to the person or put it in a shared directory. And then so that they know it's in the shared directory. We need to work this every day. And then also through the mail, that's where you're going to get your patient communication. And we really want to stress here, best practice. You should scan it in, if possible, attach it to your patient record so that when someone's looking in customer service, they can see, oh, we got the letter. Here's the letter. And then address them appropriately and get it quickly addressed. Don't let it sit to the side, because if they're asking the question and they're engaging in a written communication with you, chances are they're going to fill out the patient satisfaction survey as well. And where do those fall in the timing? Are they looking for an answer from you before they fill out that patient satisfaction form? Could be they are. And you don't want the fact that you ignored their communication to come out on that patient satisfaction. You want or maybe or that you did address it. Maybe you want that to come out on that patient satisfaction, because we are all working to and just take care of their needs and address any challenges that they have. So that's talking about mail and scanning. Let's now talk about bank deposits and ERA and EFT. With bank deposits, ERA, and EFT, payments, I tell you right now, best practice, have your payments sent directly to the bank. Banks can set up a service where, the remit to address and all the information goes to the bank, because that way you get the funds in your account immediately. Now, you may have an unapplied cash situation where you'll need to build a process around that, but you can still get the information, you get the cash in your bank account, and then you work on posting it. And then also, you can get the cash in your, sometimes when you set up an ERA file, that's an electronic remittance advice. It's an electronic explanation of benefits. It's got all the data in there, and it can electronically post to your accounts receivable system. So if you have a consolidated bank account where everything goes to there, they scan, they give you the correspondence, they take all the all the explanation of benefits, they scan it all in, they send you a file, you boop, upload it into your system, and no one is having to manually enter it in. That is best practice. That if you can work with your bank, banks offer the services, sometimes for a fee, sometimes not, so that everything can be mailed directly to them, get it deposited immediately. That's what you want to do. And then, as I said on the other slide, you want to do a bank deposit if you're actually getting checks and payments at your hospital, that you are doing that bank deposit on a daily basis. We're going to go to the next one. This is where we talk about payment posting and revenue allocation. Now, with payment posting, Oh, and I do want to pause right here for a minute just to say, again, as Shannon mentioned before, if you have any questions, send them through in the chat. She'll get them. Feel free to interrupt me. I know that we've got a lot of information to go over today, but I'm more than happy to answer any questions you all may have. But going on to payment posting and revenue allocation. Payment posting should capture all of the activity that is on that electronic explanation of benefits, an EOB. You need to capture all of it because it will include denial codes. It will include payment codes. It includes just informational codes about what is happening. And then what you want to do is the associates who are posting these payments that they're trained to spot anomalies in the payments. So if you get payments in and your payments are equaling your charges 100%, someone ought to raise a red flag about that. And why do I say that? Because very rarely do you get paid anymore 100% of charges. And so if you are getting paid 100% of charges, could it be that there is a payer, as we talked about with the payer contracting side, there is a payer who their fee schedule is higher than what your charges are. And there could be an opportunity for capturing additional revenue because you just need to increase your charges to be the fee schedule amount and they will pay you more. The other thing to have the payment poster be aware of and just spot these anomalies in the payments is when a payment is consistently short a small dollar amount. So when thinking about this, that the payment comes through and it's short a dollar here, a dollar there, or you always know that when a colonoscopy comes through, the 45378, when that code comes through, it is always short of $20 every single time. Or maybe not $20. Let's just say $5. $5 for every colonoscopy that comes through by this specific insurance company out there. And what is happening is they've done something on their side. Your contracted rate says that you're going to get paid this full amount, and they are short paying you. This is Amy Graham's personal opinion, is they're counting on the fact that you're not going to work that $5. They're counting on the fact that you will think that it costs more money to chase after that $5 than the $5 would be worth. I almost want to say, can I see it? Show of hands. Because one claim, $5, not a big deal. But you know what? If it's 100 claims, that's $500. If it's 1,000 claims, that's $5,000. And it could be that they're short paying you and you've got $500 built up in it, but you've got a neighbor hospital and they're short paying them, and you're all in the same state. If your payment posting associate is trained to spot these anomalies, they can share it with you. You can have a relationship with a nearby hospital or a hospital within your state and call and go, hey, are you getting short paid $5? And then together, the two of you can go back to the payer or by yourself, go back to the payer and say, your contract says you're going to pay us $50. You're paying us $45. Give us the other $5. You owe us, based on your contract and your fee schedule, this $5. And here are the 500 claims or the 100 claims that you need to reprocess. And then what they can do is reprocess those claims for you and send you the payment that they have short paid. But if you don't pay, going back to payment posting, if you don't train your payment posting associates to spot these trends, then that's a missed opportunity out there. And then also, when looking at revenue allocation, that you want that revenue allocation is for activity based funding and it's achieved through the distribution of payments down to a charge level. Well, what you want to do is when payment posting comes in, rather than just posting it to the account and going on and things like that, as much as possible, you want to take it down to each individual activity, to post it down to the CPT code level, or post it down to the service line level, the supply level, the payment that is received in. And then and you want to make sure that you are tracking that revenue allocation and that it is making it to the appropriate place. And then also, the final best practice with payment posting and revenue allocation is just talking about if a service has multiple billing services. So you may have an outpatient clinic that you support as well as the hospital, and you've got two different EHRs for it. It's built out of two different systems, and you've got two different companies who are billing this. Well, it could be, though, that both of those companies are using the same taxpayer ID number. And so you're going to want to make sure that your billing services talk to each other and that payments that are made to a single tax ID number are accounted for on the other side as well. That you want to make sure that it's reconciled and that payments that go into the hospital that are meant for the provider are transferred over, that they know that they can post and zero out that accounts receivable, because you don't want the clinic accounts receivable growing and then to have the hospital's credit balances growing when really they just need to allocate the funds to each other. So you want to make sure that the money is allocated down to the CPT code level, but also to the appropriate billing company. Okay, so, I'm going to take a break or take a minute, take a breath, and then we're going to start with the back end. So, back end. This typically, when you talk to people about revenue cycle, this is really what they always think of, right? They're like, oh, let's talk to billing. And then when they say billing, in our minds, we may think things like this claim submission, claims adjudication. It could be in the charge capture, but really, they're just talking about where does it stand, the accounts receivable, the claim status. And so, some claim status. So, one of the best practices is just to help your team understand that there are multiple things going on in revenue cycle rather than just back end, how's the AR doing. But then there are best practices for working the claim status and working to see what's happening in your accounts receivable. Now, with this, what you want to do is this all starts by looking at your accounts receivable aging reports. That you're going to want to take your you're going to want to go to your accounts receivable tool, print out an aging report, and then start looking at trends. You want to work payer payment dates. So, for instance, if you were to hand me an accounts receivable aging report for Medicare, I would question any charge, any accounts receivable balance that's out there greater than 60 days old. Now, why do I say that? Because Medicare, if they have a clean claim, they are paying you within 15 days. Medicare pays within 15 days. Now, I give you the window of another 45 days attached to that to get to 60, but you want to follow up on claims that are outside the typical payment date range. Why would you have a claim that's out there greater than 60 days old for Medicare if they pay you within 15 days? So you want to work based on a payer to go back to that payer and say, we've got to work these claims and we need to figure out why are there any claims greater than 60 days. And then also work claims based on timely filing limits. You may have a payer that says our timely filing limit is 90 days. 90 days timely filing limit. And that's a pretty common one. Medicare is 360. So, for me, what I would be doing, let's talk Medicare again, where I'm saying, okay, I would really check on anything that's greater than 60 days old. But I'm certainly every month, like especially like now in January, I'm going to be looking at March of 2021 claims. Why have those not been paid? It's because those I'm running out of time. I have about 45 days left. If I think about the 28 days, maybe even less than that, probably about 30 days left to collect on a March 1st claim. And so I might be looking at March of 2021 and looking at April of 2021 claims because I'm getting close to the timely filing limit that I'll have no chance to be able to collect on those claims. So that's where you want to look at payer payment dates. That's what that means is what does the date look like and work those claims to find out why, what's going on. I wouldn't focus on anything in the 0 to 30 for Medicare because you know what? Chances are they've made it in the system, they're working through. I'll get my payment. I don't need to focus on that. But I do need to focus on the ones that are 30 to 60, start looking at them, and then anything over 60 days, what's going on? And then also look at trends by payer. You know, look for, is there a consistency of the same amount outstanding? Like, do you have a whole bunch of claims that are short $45.32? And it's like, wait, why do I have 15 claims that are short $45.32? Or why do I have, not maybe not short, but why do I have this many claims that the balance is $45.32? Is it that the payer does not cover a specific test that is being performed? Is it that you have an invalid CPT code on the claim and therefore they're not paying it? That balance is still just sitting outstanding. And when you look at it, you look at the claim and how it's been posted, and you see it was denied and what the denial reason is, and that the balance is still outstanding. So you want to look at those trends to say, is there something we need to fix upstream? Is it a consistent, outstanding dollar amount that you need to address? Or the trend by payer, is there a specific provider whose claims are not being processed? Do we have Dr. Graham and none of our claims have been processed for the whole month of um, November of 2021? What's going on there? What happened to Dr. Graham? Well, you could find out that for that month, the payer did an update on the system, and Dr. Graham fell off their system, so all of those claims are still outstanding, and we need to work those claims. So look at trends by payer. Are there other things that you could see? And then another area to look at when looking at claim status best practices, focus on the appealed claims that you get the payment in, they've denied it, and then your team has done all the hard work to get the claim appealed. But then could it be that your team needs clinical support? This is when you go back and you leverage your CDI team to say, we need assistance with the integrity of these clinical claims. We need clinical support to help fight our case with the payer to explain to them why they need to pay us for these services. And so, focus on your appealed claim. Do they need additional clinical support? Does your team who's performing the appeal have all of the information that they need? If they have all the information, then that's good. But it could be that they need some additional clinical support because chances are the person who's filling out the appeal doesn't understand the actual process or procedure that the patient received at the hospital. They know it's a 45378, but they don't. And then it says that it's a endoscopy, da 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 da, but they don't recognize the procedure that's actually being done as a colonoscopy in the hospital. So that's one of those areas to does the team need additional clinical training, or do you need to engage the clinical team in just helping you appeal it? And then also on appealed claims, focus on the communications that are being received from the payer. Has the payer received the appeal? Is the payer working the appeal? How many days do you have? Going back to the payment date, start looking at the communications that you're receiving from the payer to make sure that yes, they have received my appeal. Yes, we are working it and where it stands on those appeals. And then the final one on claim status best practices, just monitoring the claims by the claim filing date. As I stated before, you can have claims that are stuck at the clearinghouse. They never left the clearinghouse. Somebody thought there was an automated process. It should have dropped those claims, but when you go check the claims in the clearinghouse, there's not a bill date on them. That and so claims may be aging out there. Go look at a date by filing date. And then also claims that are not received at the payer. Again, there could have been a blip in the power and they just did not get received at the payer. So that's another way to monitor it to make sure, you should have caught, the best practice is you catch it when the claim goes out the door and you get that response back. But there's some payers that don't give you the response back. So you have to monitor it through the claim status through your accounts receivable aging in the back end. So that's working the claim status. And going on to the next one, we are now up to denials and appeals management. So this is what I would say is rework is extremely costly and that redundant errors commonly occur in services like lab and things like that. And so what you want to do when working denials and appeals is just make sure that you are correcting the root cause. And so the first thing you want to have is, do you have a formal denial report? Does it exist? Do you know what claims are being Do you know what claims are being denied? And I want to stop here and just say for a minute that a lot of times when I am talking about denials, denials are what come back from an insurance company, as opposed to rejections where it got rejected and sent back. So it's like rejection is it hits the screen door and it bounces back, as opposed to a denial where they send it to you and they say, we are just not going to pay that claim. And so, what you want to do is one, first, best practice, make sure you have a report that tells you what your denials are. And then work through that report, work from the largest to the smallest to figure out, you know, what is happening and what can we do to address these denials and that come from the insurance companies. And then also utilize your clearinghouse edits. If it gets denied because it needs a it needs a specific modifier on it that, rejected, no modifier included, or missing modifier, you get a denial like that coming back from the insurance company, then you can set up your clearinghouse to make sure that modifier is included going forward. And then always focus on fixing the trends. You can get really caught in the minutia of a denial report if you allow yourself to. So just focus on the trends. Do you see one that didn't, you had no denial, no denial, no denial, and then all of a sudden it popped up? That's a trend because why did it go from being at, $100, $100, $100 to $1,000? What happened to make that not trend like it was at $100 before and address on and focus on that. And then going back to adjustment codes, they're going to be sometimes specific to the payer. So you're going to want to make sure that when payment posting is posting those codes, that they are capturing all the ones for the specific payers. And then you want to look at the adjustment codes and compare it and say, does this look reasonable? Do we need more codes to capture the cleaner, more accurate data? Could we, and the one I'll throw out there is CO45. Are we capturing everything in CO45? But this payer uses CO45 to be one denial reason, whereas this one is using it for a different denial reason. And then what you want to do is make sure that you update the system in the payment poster system to say, if it comes from this payer, put this denial code in. If it comes from this payer, put this reason in. So then that way you're getting to cleaner, more accurate data because one could just be an informational only and one is a full halt. We are not going to pay you. You must fix this denial. So that's what you want to do. And then just the usage. How are you using these adjustment codes? And is there thought and the reason, understanding of the meaning of these adjustment codes consistent across all of your revenue cycle teams? Do your researchers understand? Do the billers understand? Does everyone understand what the denial is that's coming through? Because once they understand all of these denials, they then partner together to fix the root cause and make it a more streamlined process. And at the end of the day, get the cash in quicker. So now, some of the reasons, like you have a CAN ID patient, insurance denied, preventative services denied for frequency, denied for lack of reauthorization, medical necessity denials, billing processes. We've given you some questions to really ask in all of these. What do we need to do? Like thinking about preventative services denied for frequency. Is the ordering provider properly tracking the frequency? Does the follow-up department report the frequency denials back by provider? So we've given you some examples of just things to do to work these claims and that when you see them coming through, because when I'm reading them to you, I'm hoping that several of you are going, yep, we have that. Yes, I've seen that. Denied for lack of pre-authorization. Yes, So just the questions that you can ask when doing this and how is this information captured? Like even thinking about insurance denied, can ID patient? Well, if we had done the insurance verification for all patients at the beginning, we should have caught this so that the claim makes it through. Although there are chances where, something was typed in wrong or it just had a blip in the system when it went through that it sent it back and you've got to capture that information. But can you prevent these things from occurring in the beginning so that the denials do not come back from the payer and you do get paid for the services that are out there? And then when working on appeals or resolutions, just make sure that you appeal or, work through all of your options that are out there. Timely filing on the appeal denial. Did you miss the window for being able to file an appeal on the claim? Was it lost in the mail because you didn't have a centralized mail processing area? Those are the things that you're going to want to look at, is to figure out why were these claims denied and why did the appeal not work. And so you want to be able to understand how the deadline was missed, and then, do you need to fix something within your processes? And then looking at incomplete denial, incomplete appeals. Did the staff get the proper information it needed? Did HIM provide enough information to support the payment? And could it be, as we were talking about before with working the appeals, that you need to get an additional clinician involved, not just HIM, but getting the actual physician themselves to be included in the discussion to understand why they did it? Because they may come back and say, I shouldn't have done that after all. Or, oh, here's what you need to say. Say these 3 words. And those 3 words magically get it done. You also want to look at denials and rejections by summary or by group. I'm giving you an example by payer where you're looking at, Blue Cross Blue Shield. Yes, they have looks to be one of our largest ones out there with the denials and rejections. But then you can see that the largest one for them is not the medical necessity. Medical necessity is actually with Medicare. You need to work with them non-covered services. So these are just things to keep in mind in working to make sure that you're looking at denials and rejections by a summary of group and by payer, and that you're monitoring what's coming through so that you can address it or to see if you have a problem out there. And then finally, we're going to talk about patient statements, collection letters, patient refunds, small balance write-offs, and the collection process. And really, this is just, you think about it before, back in the old times, historically, maybe I should say it that way. Historically, we would just let patient activities just happen after the fact. But if you've already established through your pre-visit and visit activities that the patient will have a copay responsible, it will help streamline these processes. So, when looking at it, patient statements, you want to make sure that your statements are delivered on a consistent cadence. And are you doing it, and how often is that being done? Are your patients getting a statement every 30 days? Are your statements being generated every single week? I will tell you, just personal experience, we went without sending patient statements out, and I was amazed at the cash that didn't come out. So we had like 2 weeks because we were doing a system conversion that we didn't send patient statements out. And I really regretted the fact that we didn't send that in. That was a key learning, that's for sure. So learn from my mistake. You want to make sure that you are consistently sending out statements. And how are you delivering your statements now? Are you delivering them through the postal service, through email, through text messaging? I will tell you one of the best things that we implemented at a previous employer is we put in a patient statement that had a QR code on it. The patient could scan it and pay for their bill from their phone. And it was all secure and HIPAA compliant. That was one of the best things because it did increase the payments that were coming in. And I got a lot of good feedback from the patient to just say, I could scan it and I was done and I did not have to worry about this anymore. And the information that you include on the statement, to give the patient as much information as possible, to say, here's the plan that we build, because maybe they had a different insurance, and even all through all of our best practices, we didn't catch that plan information. They can now send us the updated information, or they could have had Blue Cross Blue Shield, and now they have Blue Cross Blue Shield Anthem, and that one little change changed the process. Notate what the last payer activity was on your patient statement to say, we've received no response from your insurance company, or we've received a payment and here's how much the payment was, the balance is now yours. And then we've received a denial on the claim and now the balance is yours. And then also provide your customer service contact information, the number they can call if they have any questions, and any payment method options that are out there. Do you take Venmo? Do you take PayPal? Do we only take a check? Can they scan with the QR code and pay with Apple iPay? Then, possibilities are endless, but if you don't put it on your statement to let the patient know, chances are they're not going to use it. Collection letters. Now, patient statements, I did leave patient statements and collection letters are very similar to each other. And the collection letter could be a stronger messaging that you are sending out, where you're sending out like two patient statements, one at 30 days, one at 60 days. But then that 90-day letter comes through and it says, hey, if you don't pay this, we are going to send you over to a collection agency. That you are sending that notification out that says, here's the next step in this process if you do not respond to this letter. Tell them that information. Also give them, different methods for sending that out with the customer service contact information and payment methods. But you want to make sure that you are giving a stronger message. Could be the first patient statement that went out. It said, hey, your insurance company paid. This is your outstanding balance. And then the next one is, we received a payment from your insurance company. Here's the outstanding balance, and be like, you have ignored our previous letters. Hey, we've sent you two other net messages. If you do not respond to this one, it will be turned over. And maybe even a different colored statement so they know, oh, I need to pay attention to this. So, things to look at with patient statements. Looking at patient refunds, what you want to do when working patient refunds is evaluate to see if the patient has other open accounts receivable accounts. Could be that the payment was posted to the wrong account and you need to transfer the payment over and not send the patient a refund. You want to make sure that a credit balance is not related to an overposted adjustment, that you were expecting $50 on the payment and the payment came in at $60, and so you had done a contractual adjustment. You can reverse that contractual adjustment and take the payment because that was the insurance company's fee schedule and they pay you more than your charges. And then also to note, the CMS does have a requirement where Medicare patients are refunded within 60 days of receipt of payment. So that's a key thing to keep in mind, that CMS outstanding refunds need to be less than 60 days. What are you doing to work your outstanding payments? And then small balance write-offs. This is a key one to write off both positive, so if they have a positive balance, or a negative balance at a pre-established dollar amount. You want to periodically want to look at that, but these are best practices for taking care of small balance write-offs is to have an amount that says below this amount, we're going to write it off, whether it's positive or negative across the board, whether it's a credit balance or a due to balance, to write that off at the pre-established rate for your facility. And I believe that that is a facility decision. It could be a system-wide decision for you, but to just determine the amount that works best for your facility. And then the collection process. That what you want to do is work with a third party agency to leverage their resources. You've handed it off to them. And then how are you working that report? And then when the information is returned to you, how are you writing off that accounts receivable? And making sure that that accounts receivable you're writing off is included as a cost report adjustment. Making sure that the collection write-offs that you do, that you are handling it. And then also to say, to develop a process for both patient and insurance accounts. A lot of times we only look at the patient balances. Perhaps we need to have a collection process with an insurance company, and there are companies out there that will work those insurance balances as well. And so to work with them to just say, how do we want to handle this? It's at this age, we need to write it off, and what does that look like? And so I'm getting to time, and to say it's good that I'm getting to time because we have made it to the end of our process. I just, we're talking about transaction processing and back end, and I just thank you for your time and your participation. And I know we've got 2 minutes for Q&A if anyone has any questions. Feel free to put them in the chat box again. Or if you would like, you can reach out to myself. This is my contact information, Amy Graham. And as I've said before, I really enjoy talking about revenue cycle with people. So feel free to call or send me an email, whichever you'd like. Or you can also reach out to Shannon and team, and they can get the information shared with me as well. And then the last slide on the deck are just some other resources that you can refer to. A lot of this information is out there on the center's website with just, assistance for you that they've provided. And to say, if you have any questions about any of it, again, feel free to reach out to me. So, Shannon, I'm like right at time. I'll hand it back over to you now.
Thanks, everyone. And thank you so much, Amy, for your time. I think this series is really excellent. In our last couple minutes here, Caleb's going to pull up some post-poll questions for us. And as Amy said, please feel free to chat in any questions. But I'm also putting a link into the chat for the request for implementation technical assistance. So if there are any areas that you feel your organization could really use support based on the areas that Amy covered the last 3 webinars, please feel free to submit a request at any time online, and we're happy to work with you to help address any specific concerns that your organization has. And we'll follow up on that. Just a couple of reminders, all of these webinars are recorded and the slides will be made available on the website as well. Caleb on our team will email those out as soon as they're available. And then please be keeping an eye out for an email from Caleb this afternoon, which will include a link to a SurveyMonkey assessment. We'd love to hear from you on how you thought the series went. And then if anyone is interested in the credits through the American College of Healthcare Executives, please fill out that link as well. But thank you, Amy, so much for your time. This was an excellent session. We appreciate all of you joining us and taking time out of your day. Hope you all have a great weekend.
Thank you all very much. Have a great weekend.
Thank you. Bye-bye.